Be inspired, supported, and empowered. This is the Global Healthy Living Foundation podcast network.
Welcome to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. I'm Stephen Newmark, Chief of Policy at the Global Healthy Living Foundation.
And I'm Zoe Rothblatt, Director of Community Outreach at GHLF.
Our goal is to help you understand what's happening in the healthcare world to help you make informed decisions to live your best life.
And today we're joined by Dr. Mojola Omole, who is a breast surgical oncologist and general surgeon with the Scarborough Health Network in Toronto. She is president of the Black Physicians Association of Ontario, a consultant for anti-Black racism and anti-Black oppression training, chair of specialist issue in the CMAJ on anti-Black racism in medicine, and chief medical officer. She also hosts a bi-weekly podcast with the Canadian Medical Association Journal, and her podcast explores the intersection of scientific advancements and social health issues, amplifying voices of patients, clinicians, and advocates. Welcome to the Health Advocates, Dr. Omole.
Thank you so much for having me.
Can you start by introducing yourself to our listeners, your background, and what it is that you practice beyond what we have gone over already in your bio?
So I'm a general surgeon and a breast surgical oncologist. So as a breast surgical oncologist, my main focus is breast cancer. I do other cancers, but my background training and specialty is breast surgical oncologist. So it's involved in the care and management diagnosis of breast cancer. I also do work as a DEIA consultant for medical boards and different organizations in terms of anti-oppression and anti-Black racism training. And I'm also the president of the Black Physicians of Ontario.
Awesome. Well, we're excited to have you and dive into some of your work. But before we do, I want to ask, how did you choose breast cancer?
That's a really good question. I can't remember. There were a lot of things I didn't enjoy. The OR. I was like, I don't love lung cases. I don't love this. And so quite a few of the things that I do was because I'm like, oh, I didn't. But then I really enjoy breast cancer. For me, it's like I really like the connection of being able to do advocacy work, being able to do community outreach. And unlike other cancer domains, it's a much longer longitudinal care that's associated with breast cancer typically. And I really love the multidisciplinary aspect of it. So that was part of the reasons I chose breast.
That's great.
Interesting. In terms of your advocacy and work on anti-Black racism and anti-oppression training, you're a strong advocate, obviously, for patients and clinicians. Well, what are your main goals, what you're trying to achieve?
So I would say that, especially like with my work with the Black Physicians of Ontario also, there's like two prongs to it. One is for advocating for increase of Black physicians in Ontario. Currently, Black Ontarians make up about 4% of the population, and Black physicians only make about 2% of it. We know when there is racial and ethnic concordance, there's an increase in better care that patients receive. There's been studies shown from maternal health. And to be frank, all of our data that we use in Canada is from the US and the UK, because in Canada, we don't collect race-based data. But we know when there's racial concordance, pregnant people and their babies do better. We know that there's just differing treatment. And so part of what we advocate at the Black Physicians of Ontario is to increase the amount of Black physicians in medicine. Once we have there, we also have to maintain well-being. And part of that is there's quite a lot of like systemic racism that people are just not aware of, and being able to advocate to help people to understand what that looks like. I always say when I give workshops that we're all capable of anti-Black racism. Even Black people are capable of anti-Black racism, and part of it is being able to understand what our positionality is, and that way we can better combat anti-Black racism. And finally, it's just community outreach to increase health awareness around different diseases. I'm very passionate about oncology, and so breast, prostate, and also maternal care. That's another thing that we do quite a lot of advocacy work around in terms of outreach to the community. Also, Black mental health. So in terms of just having the community understand how to access resources, how to advocate for themselves, because it is quite challenging when you're someone, whether it's racialized or you are of a different gender, different sexuality, there's barriers when you try to advocate for yourself.
And can you talk to us a little bit more about some of the maybe underlying reasons of why there's such a small percentage of Black health workers in the workforce, and some of the steps you're taking to improve that?
I would say that one of them is that if you look at most medical training, people are legacy students. I also am a legacy student. My father was general surgeon. I have like a very different upbringing. I also grew up in like rural Ontario, but I have a very different upbringing when it comes to being able to be savvy in terms of navigating the system. That that is a huge barrier. Lots of people have dreams to become doctors, but not a lot of people have the financial means to do it, because it requires you to take your summers off to be doing unpaid work, unpaid research. For some people, that's just not possible for like many people in the racialized communities to do. And also just understanding how to navigate the system to increase your GPA, the extracurricular that's needed, and how to do your application properly. All of those things are barriers that when you have someone who is in medicine in your family, or even like your neighbor is a doctor, so you can go to them to ask for help, that really changes things. And for a lot of our Black, Indigenous, and racialized folks and low income folks, that's just not something that they have accessible to them. So that's part of the work we try to do at BPAO. Is I always say that I was lucky that my dad was my first mentor, so I want to be the first mentor for other people too.
Yeah, that's amazing that you're doing that. And it's so interesting because it really mirrors the conversations that we have in the patient community of like that peer-to-peer support and navigating the system. And I just hadn't thought about it so much from the provider perspective of how much you have to navigate early on.
I was going to ask, you're chairing a special issue in the Canadian Medical Association Journal on anti-Black racism in medicine. What is this special issue going to do, and what key problems does it expose?
So that was released last year, the special issue that we did. And that really was to bring to the forefront what anti-Black racism and what systemic barriers look like in medicine. And so we had topics that was looking at mentorship in medicine for Black medical learners. We had topics around prostate cancer. And for example, in Canada, PSA is not routinely done. But there's an argument that measuring the prostate-specific antigen in Black folks, because Black people have a higher rate of prostate cancer and more aggressive prostate cancer, that should be included in the screening. So oftentimes what we're doing is that like we don't want race corrections for different tests. However, we need to understand that whether it's breast, prostate, or other diseases, we just have a different biology, and that not one size fits all is what works. And so part of that was to advocate for and to talk about the differences in managing different disease processes and also just navigating the system that Black medical learners face.
And actually, I have a question on that. Can you talk to me a little bit about how you navigate the idea of maybe over-screening, but also accounting for the differences among populations like you're mentioning?
I think that it's important to understand, and I do my work around this in breast mainly. I know just a little bit about prostate from doing the special issue, is that I think that we misuse the word over-screening and not necessarily understand that there's different biologies to different types of cancer, and that there is a difference in the oncological outcomes for different groups. There's a breast surgeon named Lisa Newman in New York, that's all I remember. And she's coined this term anthropological oncology, and is that different people have different subsets of biology. And so this is looking at people from the West African region. I use the word people, not women, because just to also be inclusive of our trans and non-binary folks, because they also still get breast cancer. And that when you look at the tumor biology of breast cancer in West Africa, and it's very similar to the biology of Black Americans and the Caribbean because of the transatlantic slave trade. Like that is the same gene pool that's traveling. When you look at East Africans, they have a completely different tumor biology, and it actually mirrors what you would see in the Middle East, because East Africans that were part of the slave trade went to the Middle East and not to the colonies in the US and in the Caribbean. And so that our DNA is just, I'm West African, I'm Nigerian, so our tumor biology is just different. Like we present differently and we do differently with the same medications. And so therefore we should screen differently. So for example, in breast cancer, the median age of presentation is 63 years of age. But when you actually look at Black people, the median age of presentation is 45. So you have to screen those populations differently. It's not a one size fits all. When I talk to patients, we always say every breast is different. So if that holds true for management and treatment, that should also hold true for screening.
Yeah, that makes a lot of sense. And is this something that's taught in medical schools, or is that part of your work now to get people more aware of these differences?
It is not taught in medical school. Medical school is wholly lacking in having an understanding of how different populations present with diseases. Part of some of the work that the CanMed, which is kind of for in Canada, the governing principles for medical learners, is trying to revise, is that we need to put this in there. We need to be advocating that different populations present differently. For example, things that I know I'm mainly from doing the CMAJ podcast, like the treatment for gout in Asian population actually can cause severe illness illness and death because they don't have a gene that allows them to metabolize it. That's not taught in medical school. That's not even taught in residency. But these are the kind of things that we need to start incorporating, is that we need to teach students, okay, this is the things that you need to know, but in certain populations, these things can be different. But we also have not researched them. So like this wave of researching, of making sure that we're including ethnic variations, is very new.
Yeah, my background's in public health, and I've just learned a lot about the lack of research on these topics and
For sure.
like how necessary it is to start teaching early on about this. We talk a lot about here in our organization about how psoriasis and different skin conditions are often taught in medical school using images of white skin, and there's such a lack of diagnosis because just something as simple as images are not inclusive.
Yeah, and there's some people in Canada who've been doing work around it. There's a dermatologist out at Memorial. His name is Bolu Ogunyemi. He's been doing quite a bit of work in terms of trying to update text to include variations of skin conditions in darker skin tones.
It's amazing and such necessary work. I mean, we know the time to diagnosis is a huge challenge. And I guess in thinking about that, you've done a lot of work around breast cancer screening. And I was hoping you could describe the issues around that and what you think the recommendation should be. I think there was a recommendation by the Canadian Task Force on Preventative Healthcare. Can you talk to us about this?
So the recommendations, they say it's a draft recommendation, but I'm like, you publicized it, so not much of a draft. And it's open for consultation for like 2 weeks for people to have input into it. Their recommendation is to start screening at 50 and to do it every 2 to 3 years. This is against every other task force, whether it's the UK or the US task force, that recommends screening starting at the age of 40 and to do it yearly. In addition, the Canadian Radiologist Association has also said screening should start at 40 and it should be yearly. So they're in direct opposition to other task forces. I would say that probably one of the driving forces that's not clear there is that this is a cost analysis, and this is not necessarily of lives being saved. So as I said, the median age for Black women is 45. So you want to start screening 10 years before that. So technically you should actually start screening at 35. And there are some US groups that advocate for screening much earlier in Black women. So Black women, Asian women, and Hispanic women all get breast cancer at least 20 years earlier than what is noted in Caucasian women. And this is documented in the data. And so they say that there's no randomized trials in Canada, but we can't do that because we don't even collect race-based data. But if you look at the US data, it's quite robust and it shows that there's a difference in there. And we know that if you actually, you get the most bang for your buck, both in lives saved in young women with breast cancer. So that's like the 40 to 50 age, that we actually, the data shows that screening at that stage saves lives. The majority of Black women do not get diagnosed by a screening mammogram for breast cancer. They come in with a physical symptom. By the time you can feel a lump in your breast that is a cancer, it's usually around 2 centimeters. So that completely takes you from stage 0, stage 1, to probably stage 2 breast cancer. So there's more aggressive treatment versus doing when you have a screening mammogram and you find something at stage 0, stage 1, much less intervention that's done at that stage.
And why do you think there is such a difference from what this task force recommended to, what you're saying, Canada's neighbors are doing?
I think it's money. I think it's about cost savings, because they even said to stop screening at 74. To me, that's just ageism. My mom is 80 and she's just on 2 medications. And so why shouldn't she? She's not going to die anytime soon, God willing. So why should she not continue to get breast screening? And they put it in there, the caveat that, if people want to get screening at 40, it could be a shared decision with their family physician. The problem with that is there's a lot of people who don't have family physicians, and the self-referral to breast screening differs across Canada. BC is 40, so if you're 40, you can go yourself at 40 and do that. But until the fall, that's not available in Ontario, and it's not available in Quebec and in the eastern provinces. So there's quite a variation, and so we're allowing more people to be diagnosed at later stage breast cancer and have more treatment than having earlier stage. And so to me, it just seems like it's a cost analysis and not so much about lives being saved.
And I imagine, that makes such a difference for insurance coverage. if the recommendation is later and to cut off at a certain point, even if like you're saying you can go to your family physician and say, I want this, I bet there's a barrier then when you try to get coverage for that screening test.
For us, because we're like universal pay, there's no issue with coverage.
Oh, okay.
So like you're going to get it free, but we don't like, there's a lack of family physicians in Canada. Like people don't have primary health care. I can't remember the data. I think up to like 20% do not have a primary health care physician. So they're using like episodic care and walk-ins, and that's not the right way to be getting routine screening, whether it's your mammogram, whether it's being sent for colonoscopy, or whether it's like a pap smear. Like people just won't go.
Oh my gosh, what I'm hearing from you is we need more family physicians, we need more Black providers, and we need better guidance around screening. There's a lot to do.
We do, yeah.
Well, we have a lot of work to do, I guess, both in Canada and south of the border as well. As we wrap up, I just want to ask what advice you might have for other providers on how they can advocate for their patients.
I would say that the main thing is to ensure that you're up to date, that you just don't go with what the task force says, but that you get to know your patient and understand their risk factors, and that there might be ethnic variations with each patient, and trying to learn more. I mean, part of our role as providers is lifelong learning, and this is part of it. So staying up to date so you can inform yourself. It is very challenging because family providers have so much that they have to deal with that it's hard to stay on top of it, and that's why we need better guidance from our governing bodies and from task forces. So it is easier to get the information, but the onus is put back on us as physicians to be doing that right now.
Great. Well, thank you so much for your time today and for all that you're doing on behalf of patients and the entire medical community. This has been a real learning experience for us, and we look forward to talking more about it.
Thank you so much for having me.
Thank you so much for joining us, and hopefully next time we chat with you, we will have increased that 2% number.
Yeah, let's go.
Well, Stephen, that was a really great conversation with Dr. Omole. What did you learn today?
Yeah, for sure. I guess a very specific learning is I learned that 4% of the population of Ontario is Black. I did not know that. And 2% of the doctors in Ontario are Black. So that's just doing my basic back of the envelope calculation. That's half of what it probably should be to be representative of the population itself.
And for me, it was really interesting our conversation about the lack of research on a lot of these disparities in healthcare. And it's not taught in medical school, and there also needs to be more efforts to research and learn about these differences.
Absolutely. Well, we hope that you learned something too. And before we go, we want everyone to check out all of our podcasts at ghlf.org/listen.
Well, everyone, thanks for listening to The Health Advocates, a podcast that breaks down major health news of the week to help you make sense of it all. If you like this episode, give us a rating, write a review, and hit that subscribe button wherever you listen. I'm Zoe Rothblatt.
I'm Stephen Newmark. We'll see you next time.
Be inspired, supported, and empowered. This is the Global Healthy Living Foundation Podcast Network.